I'm going to ask Professor Regazzoni to come up. It's been an extreme privilege and honor to have one of the original innovators and the pioneers in the AO joining us for the Trauma Summit. Professor Regazzoni.
Thank you very much. This is a forearm lesion on one bone. And who thinks that this is an easygoing, straightforward healing case? Please raise the hand. Okay. Who thinks that we will have significant problems in this case? Okay, who thinks this is a case for minimal invasive therapy? Raise hands, please. Minimal invasiveness is fashion, isn't it? Okay, nobody, okay. The person who treated that made this. And said, I have just made 2 small incisions and the slit plate. Who is happy? Raise hands, please. Who is happy? Oh, thanks God, so I can stop and I can go, because it's clear. This was a slit plate, a simple fracture. After 6 weeks, you have still the fracture visible. It's a simple fracture, so I want to say it from the beginning. It needs a stable construct and somehow a conventional internal fixation. MIPO is maybe good, but I think not so important. But it's for sure not a goal per se. Now the question is, does an LCP help anyway? I think not at in this age group, because the advantage is that you have a better anchorage. But if you see this, at 26 weeks, a fracture which should have been healed after 6, I think this is acceptable. And so we have to come to this. MIPO, minimum reduction, invasiveness, stability, LCP, variable angle. I think we have got a little bit of confusion. And what are we talking about? I think minimal invasive surgery is a great thing if it is possible. What does it mean? We want to minimize the window of approach, thus minimizing the additional trauma to soft tissue and bone, using indirect reduction if possible, and minimal additional trauma at the fracture site when direct reduction is used. But 2 things. This is good if it allows us to do what we learned many, many decades ago. If not, please stick to the old principles, because they still remain true. And this, the last point is important. Instruments leaving small footprints. What does it mean? The majority of our instruments have been developed in an era where open surgery was practiced. And we need a lot of modern instruments, and I come in a second to this, to be able to do minimal invasiveness and to leave small footprints. But the incentive for our partners, the industry, to develop these instruments is not very big, because what they do sell is implants, and what they give in consignations are instruments. Sorry, I think we have to think about that. But it's clear that it is a problem. So again, minimal invasiveness is an advantage if it is possible, but not a goal per se. And for sure, it is not an excuse for articular incongruity, the so-called OIF, open internal fixation without reduction, or even worse, this OI, means open internal impairment. Okay, so this is unstable fixation in a shaft, like the one we have just seen, is unacceptable. Dysmetry or malalignment for sure also. Okay, now, why should we again start to, like in the old days, start to talk about stability? Maybe there was one unfortunate thing in the evolution, and it was the introduction of the term absolute stability. There is nothing absolute but the Lord above. So it would probably have been better to say sufficient stability for the given situation or the given goals we want to reach. And stability is not something, it's something you can measure. It's the load limit before interfragmental movement is occurring. And you can measure this. This is an osteotomy model and different fixation techniques. And then you can measure it. And you can see here, this is the normal intact bone. And you can see that with this type of fixation, just axial compression with eccentric screw or a tensioner makes a completely unstable fixation. From the very beginning of load, you have movement. And if you combine, and this depends on the dimension of the bone, if you combine pre-bending and lag screwing and axial compression, then you can up to, let's say, 100 to 120 centimeter kilopond, you can have a stability comparable to the normal bone. But I think we have to remember these things. And then we have to know what we want. Stable for functional treatment, consolidated to allow full weight bearing, and remodeled to allow implant removal. I think these are very basic, but it's clear. So if we have such a situation, we have to restore articular congruity and no concession is allowed. If possible, you have to have an anatomical reconstruction, stable fixation, and the invasiveness is just secondary. So we remain simple fracture. We need to have a stable fixation. LCP, yes, it's just more expensive. If there is a reason to need better anchorage, like in porotic bone, it is an advantage. And for sure, there is no primary loss of reduction. And then let's not forget the basic things we have learned. Our modern plates are fixators, therefore following the biomechanics of fixators, where the most important stability factor is the distance from the bone. Clearly, if you have an external fixator, this distance A is relatively big. If you have an internal fixator, it is much better because the fixator is close to the bone. But we have to think also of other things. We discuss about, less rigid fixation and all these things. We have to think about the stress distribution. And Stefan Perren has told us lengthily. You see, we have on one side the stress distribution. If we go close to the bone, we have this segment where the whole stress applied will be distributed. If we have this other bridging, the stress distribution will be along this longer segment. So it's also clear if in this segment we have only one fracture line, simple fracture pattern, where the stress is distributed, we are at risk. If we have a multifragmentary fracture, then for sure it's an advantage to bridge, because you will have the stress distributed over the long segment. It's trivial, but unfortunately often forgotten. And here it's a simple fracture. You see, this is it's just clear because of the stress distribution. So it's dangerous. And in the complex fractures, you have the advantage that you distribute the stress through the whole long segment. So stability is not an absolute goal, but it's sometimes needed. So let's try to summarize. Simple fractures, if articular, anatomic reduction, absolute stability. In the shaft, whenever possible, a nail, but avoid a gap, because this is a model of delayed union. If for any reason you need a plate, please remember the first case and make it stable, because of the strain distribution. High strain, short segment, stability needed. Complex, low strain, because distributed on many different things, relative stability sufficient, bridging enough. And this is the consequence I have anticipated already. If for any reason you have to plate a simple fracture, then stability is and remains an issue. In complex shaft fractures, you understand why nailing is the way to go, because you need only axis length and the rotation. And in articular fractures, do it as anatomic as possible and tell the patient information that probably he will remain, as we have seen in the brilliant lectures we heard before. What can we learn? It's not the toy. It is the sound and skilled application of principles that gives good results. The basis being case analysis, preoperative planning, and gentle soft tissue healing. Analyze and then use out of a big box of your toys the one which best fits your needs. And if we do this, we can take advantage of what the modern technology offers, but as Pipino says for the prosthesis, for the minimal invasive hip prosthesis, yes, if I change the design of the prosthesis and if I then adapt the selection of my patient to those who are adapted for this type. So not just shorten the incision and make the surgery as before. Minimal invasiveness, percutaneous internal fixators, yes, if by modern imaging, if transposing modern imaging into the OR, we can do things which used to need a big exposure, which we can do percutaneously. Yes, provided the most important part of the whole thing, which is reduction, remains good. Because a percutaneous SI fixation, if the reduction is bad, and I just made 2 percutaneous screws, that's for sure not the goal. And so this is the way to go. So let's try to take advantage of the new evolutions and not being just slaves of fashion. Thank you, and sorry for being extremely trivial and maybe old-fashioned. Thank you very much.
So, Dr. Ring is going to start off with some outcome of upper extremity injuries, how to do it, and what have we learned. Dr. Ring.
Thank you. If impairment is objective pathophysiology, so let's say can't bend your arm beyond here, that's an impairment, or you're numb, or you're weak, or you're atrophied, those are, that's what impairment is, loss of bodily function. And disability is inability to perform. And so outcomes is, I guess people were saying that the symptoms and the disability were more important than the impairment, is mid-90s, late 90s, what people were saying. So this is what we did when I was a fellow. We just basically gave everybody the DASH, which is arm-specific disability. And if you look at this graph, this is a group of patients, 68 patients with a common hand problem. And this is the DASH score. 0 is perfect. You can do everything that you want to do with an arm. And 100, if it went out to 100, would be no arm. So you got to stop and think. It made me think, what diagnosis in hand surgery, and it's a common one, non-traumatic, would cause this type of range? Is there any diagnosis that, where the impairment or the pathophysiology would explain that? And this is a single trigger finger. So Does that not open your eyes? It opened mine. I had to understand that. So here's a patient of Jesse's. I'm doing a research follow-up. She's in her 80s. She had ununited, unstable, non-union of the distal humerus. Her arm was pretty much useless. So he fixed it. He got it healed. Now look at her impairment. She's got 60 degrees of elbow motion. Not great, right? It's pretty terrible. What's her DASH score? 1. So she's very impaired but not disabled. Here's another patient of Jesse's, comes from another paper that we did together. This woman had a dislocation of her ulnar humeral joint, chronic dislocation. Yes, it does occur in the United States and in wealthy countries, and it was out for longer than 2 months. And he put it back in, put a hinge on, and it's stable with full motion. And her DASH is 29. No ulnar neuropathy, no nothing. Painful, and of course I would expect some pain, but her DASH is 29. So that's a pretty substantial disability level. And so this, again, is very eye-opening. It's what is going on here? What is the placebo effect? It's your inner healer. It's you willing yourself well. It's health. It's an important part of health. And that's where the symptoms and disability, again, that's what ties it together. That's what explains the difference between impairment and disability. And what we've done, the work we've done in others, and just building on what's been done actually in other fields, we certainly know that disease and pathophysiology has a role. Orthopedic surgeons are very familiar and we understand the role of secondary gain. If it benefits you to be ill, you will have more illness behavior. But what we don't understand, which is common sense, maybe we understand it, but we don't appreciate it, is that if your mood is higher, things don't bother you as much. And if you have effective coping strategies, I can do it, everything will be fine, I wish this injury never happened, but I can still do what I love. That kind of thing. I can adapt. I can get my earring on with my other hand. I'll be fine. So that if you have more of this, and you can build these, you can cultivate these, then you do better. So pain, again, words that help you get this right. Pain versus nociception. Nociception is the physiology of real or potential tissue damage. So you pinch yourself, and the receptors start to go off and sends it up to your spinal cord, gets gated, goes up to here. And then pain's what you do with it after that. So if you're, you can talk about athletic examples or battlefield or whatever. The pain doesn't bother you as much. I mean, I like to talk about pain where you're doing a healthy stretch or working out or running, and you just kind of file it in a different place and keep going. It feels healthy. The nociception is there, but it's not really that painful. And then, of course, you can have a whole lot of pain without much nociception at all. So I can't. Disability is really I can't. I can't do it. And again, these are the things that really determine the disability versus impairment. Okay, so I saw that graph of trigger finger, and I put out this ad, I think, for Harvard medical students to come work with us. And I put a little bit of that in there. I said, we're going to try to research this. And a psychologist that worked at Dartmouth with the back pain guys like Jim Weinstein and stuff, she came down and she's like, oh yeah, I told her my story. And she says, oh, we can measure all that stuff. It's this, and this. We measure it in the back. It correlates highly. And I was like, wow, we're way behind. So we did it. And one of the first things we did was look at 5 common diagnoses. This is a non-operative distal radius fracture about the time you get your cast off, and these are other things. And this is a measure of symptoms of depression. People think of depression as all or none, but we know that's not the case. It's symptoms of depression and disability. And look at the correlation. Not only is there correlation, but it's the same slope. I mean, it's just, my statistician couldn't believe it, but it's really impressive, and it really gets your attention. Now, when we talk about I have a high threshold for pain, people chuckle because we know it means the exact opposite. But what does it really mean? You got to listen to what your patient's saying. And I fully admit that I am not naturally good at this. And I work very hard at it because I know it's important. But communication skills and empathy, and they're telling you, doctor, I don't usually complain about pain. So if I'm telling you about this, something's seriously wrong. That's what they're saying. And they might be saying this, you're not listening, and you might be listening, but they don't feel heard. Okay, that's the thing. So whatever you're doing, they don't feel like you're hearing them. So you need to start saying, Do I have this right in repeating their words back and saying, that must really be terrible? I can imagine how you feel. I would say something nice like, wow, I can't imagine you deal with this so well. You're in such difficult circumstances, but yet you're doing so well. And so they also feel dismissed, and they'll tell you that. The doctor comes to you and, Dr. Fisher dismissed me, so I'm with you, Dr. Ring, because you're going to fix me up. And, they do feel that you've got to make sure that they are heard. And the real bottom line is they're saying help. So now some of the things that represent ineffective coping strategies are these cognitive errors. Psychologists can come up with some pretty harsh terms for things, but I'm not sure error is the right way to do it. But it's sort of, because I think a lot of this is, I can sum all this up with that I'm pretty sure that we have evolved. This is a non-psychologist trying to figure out. I'm pretty sure we've evolved and that it's an evolutionary advantage to react to pain protectively and to imagine the worst. I'm pretty sure that was an evolutionary advantage. Like if you hear a rustle in the bushes and you just said, that's probably not a bear. One out of 1,000 times it was, and so you were eaten. I like to talk about my daughter's guinea pig, who she loves and cuddles and feeds and cares for, but when she reaches in the cage, he runs away like she's going to kill him. I mean, we're a little bit like guinea pigs, not even close to as bad as they are, but this is like, it's taking too long, it's never going to heal, I'm not going to be able to do what I love, I'm causing more damage, I shouldn't feel this way, I'm too young for this, I just find the right doctor, he'll take care of it. That's the things that come to mind, and it's really just sort of thinking the worst. What about this? What about when you get an MRI and it's normal? That's actually hard to do. It's actually hard to have a normal MRI. But what if you do? What if the patient looks glum? That happens, right? So that's preoccupation with, or if you just got to ask people that know, just talk to people that know, like experts in other fields, preoccupation with or fear of having the idea that one has a serious disease based on a person's misinterpretation of bodily symptoms. And then it's actually add to that in spite of reassurance to the contrary, like a normal MRI. So it's a somatoform disorder. It's a dysfunctional pain alarm or symptom alarm, imagining the worst and believing it. And when you're intuitive, I think you're more susceptible to this just based on your personality, because it's hard to separate thought from fact. When you're intuitive, you don't like doing that. You tend to trust your thoughts. So this is a word that is completely stigmatized, and so you have to use descriptive terms like heightened illness concern. But it does capture something that we all deal with every day in every field. It's a disabling illness to be ruled by those thoughts. If we can help our patients have the best possible mood, the most effective coping strategies, and address any tendency towards heightened illness concern, of course there's secondary gains in there that we face, then we can help them be healthy. So now let's come to the real bugaboo, and we've already talked about it this course, is what does this patient have? This is the best flexion she can do about 6 months after distal radius fracture. So we would call this RSD or CRPS, but let's think this through. So talk to your experts. In this time you talk to sociologists, and they will describe to you a social construction. It's any phenomenon that is invented or constructed by participants in society. It exists only because we agree to behave as if it exists. Any thoughts about social constructions in medicine? What is an example of an illness that exists because we behave as if it exists? Anybody? Fibromyalgia. Somebody always says it. I know you got to be brave because you feel you're going to piss people off, but this is not, listen, this is a good question. It's a clear question. So we do have these. How about whiplash? Whiplash is safe, right? Whiplash, that's easy. I would say repetitive strain injury. We do see signs that that's going away. In Australia, they got rid of it through the courts. Brilliant story, if any of you don't know it. What about, some of these may fit, and I actually think maybe this one. Maybe that. Because what is this really? Let's just describe it. It's disproportionate pain and disability. That's it. So whenever we try to put a label on it, it's like fibromyalgia. It's fibers and myalgias. It's muscles and fibers and stuff. It's like we know what we're doing, but we don't know what we're doing, so just describe it. Disproportionate pain and disability, and just leave it at that. And I've got through telling you what determines that, at least as far as the best evidence today suggests. So listen to your patient empathize, legitimize their concerns, understand that they're thinking the worst and believing it, and don't necessarily try to talk them out of it, but invite them and give them the information and the empathy and the compassion they need, and encourage them to change their mindset to a healthy stretch, and you'll see things transform. So we need to. I use things like analogies. I talk about magic with them, as I mentioned. I talk about fire alarm. Smoke alarm goes off all the time when I'm cooking, but it's never a fire. That's how it's supposed to work. It's supposed to go off with just smoke, not supposed to wait for a fire. But you got to be able to filter that alarm and know. Now, in terms of, I think I'm too enthusiastic about this, and my most recent lesson is just hold back, wait for the buy-in. In the end, there's something that works. It's called cognitive behavioral therapy. But we may not, I think we can have elements of that in how we talk about things, and I think there's been some research in Canada with physical therapists, and that's shown some, we think we should do more of that. But really for us, it's more of these things. It's empathy, communication skills, wait for the buy-in. Don't do too many tests when you know they're going to lead the wrong way. Don't medicalize things by giving shots just because, and just kind of just support and do, be more of a human. But in the end, again, I think that this is a human thing. We often, all of us have trouble sometimes distinguishing thoughts from facts, particularly when our mood is low. And some of us have less effective coping strategies. It is circumstantial, cultural, etc. It's very complex. It's very human. But all of these things are addressed by cognitive behavioral therapy, which basically teaches you how to distinguish thoughts from facts in a way that you can, what does it do? It helps you bring out the placebo effect, this is what I think, without the shot and without the pill. This way, just like, wait a minute, let me take a step back here. I'm thinking this is what's going on, but maybe it's not so bad. Let me talk to my experts. Let me be ready to be wrong. And that's kind of, cognitive behavioral therapy is not so easy for everybody. So this is kind of a systematic way to learn how to do that. Not sure if that's what you were expecting when you asked me to talk about outcomes, but thank you.